Continuous electrocardiograph monitoring is standard in nearly all ICU patients. Arrhythmias are a common complication of ICU care. Contributors include medications, electrolyte abnormalities, primary pathologies, and underlying comorbidities. Up to 20% of ICU patients suffer from a significant arrhythmia during their stay, the most common being atrial fibrillation and less so episodic ventricular tachycardia. Continuous monitoring with audible alarm systems allows detection and early intervention of these potentially significant dysrhythmias. Despite constant manual surveillance, continuous EEG monitoring fails to detect significant arrhythmias in clinically unacceptable rates. Automated rate alarms address this somewhat, but may miss important self-limited dysrhythmias. Newer algorithms allow detection of these rhythms with greater accuracy and have been validated in both ICU and CCU patients. Automated ischemia monitoring has also been developed. These systems detect the J-point of the QRS complex and compare changes to the isoelectric line. To be accurate, this system must also analyse for dysrhythmias which may interrupt interpretation. Monitoring can be done in multiple leads simultaneously and displayed graphically to show change over time. To this point, evidence of efficacy in the general ICU population is lacking. Continuous ECG monitoring also facilitates the production of standard 12-lead ECG tracing. A number of limitations exist. A lack of outcome studies is apparent in the literature outside the context of myocardial infarction, but it is clear that this intervention is relatively harmless and potentially highly beneficial. A number of leading authorities, including the American Heart Association, recommend electrocardiographical monitoring for all patients admitted to the ICU, regardless of their cardiac status.